尊敬的各位同仁，大家好，这是旅美科协组织的30年庆祝活动系列之一。我们今天非常荣幸请来2位业内专家，一位姚博士，一位杨博士。2位博士呢都有各自的不同特长。我们的第1位嘉宾是我们的 Dr. Joseph Yao， 第2位嘉宾 Dr. Xin Yang。 The first speaker, Dr. Joseph Yao, is currently the director of the viral hepatitis and HIV COVID testing laboratory at the Mayo Clinic, 梅奥医学中心, and he has been the associate professor and also the director who has been contributed to the medical research, particularly focusing on the internal medicine, infectious disease, and also microbial-related topics. So Dr. Yao has been made significant contribution to the infectious disease in the development of different types of assays, diagnosis tools. For this, he received different significant honors, especially the Fellow of the Infectious Society of America, and also the Fellow of American College of Physicians, and many others. So Dr. Yao, if you are ready, the microphone is yours. Yeah, please take it over.
Thank you, Professor Liu. 谢谢刘教授的介绍。您可以看到我的视频吗？
非常好。
好的，好，谢谢。在此我再感谢旅美科技协会邀请我来参加这次的讲座。那么我今天呢就在40到45分钟，讲我们的经历，怎么样在经过这个新冠大流行，的这个经过怎么样生还，还有得到了一些什么教训和经验。So I'm going to use the next 45 minutes to discuss how we survived the pandemic over the last 2.5 years and shared some lesson learned with the audience today. I'm going to cover what happened in the beginning. If some of you can remember, in March to May 2020, when we had our first case of COVID-19 in the state of Washington, just north of Seattle. And we'll talk about what we did in our laboratory, some of the challenges that we face, and then lastly, some of the lessons learned. So as you know, in January, towards the end of January, the CDC reported the first case of, back then we call it novel coronavirus of 2019, in a state, Washington state resident who returned from the Far East. And then the following week, the US declared a public health emergency. And then the following month, on March 11, WHO declared the COVID-19 as a pandemic. So you can see that in China, on the left-hand side, their first case started in January in Wuhan, and then quite rapidly by March 8th, almost 2 months later, it had reached 80,000 cases, whereas the rest of the world was about approaching half, including the United States. So this is the date, March 11th, that we actually launched our first test at our institution here at Mayo Clinic. And you can see by that time, China is still the major site of all the cases. And of course, Europe and Middle East, few cases in North America at that time. So March 12th is when we launched the test. And then fortunately, Roche Diagnostics, 罗氏公司, launched the first fully automated SARS-CoV-2 molecular tests in the United States and received emergency use authorization from the FDA on that same date. And we typically in our institution take about 2 to 3 months to launch a new test after it's been approved by the FDA. And this was to us a record time. From 12 to the 18, we only took 6 days to launch a test in our institution. So we actually had almost 20 people working for straight 111 hours over the weekend to launch this test. We started the assay verification, built the tests in our lab information system. And then at that time, we only had 2 cobas 6800 systems that can generate 2,600 tests per day. And we also immediately went into a 24/7 operation. Instead of our usual 2 shifts a day, Monday to Friday. And then our lab usually closed on Sunday and Saturday, we only have 1 shift. So just within 1 week, we had to recruit extra personnel from our laboratory to turn into a 24/7 operation. This picture here on the left lower corner is the cobas 6800 system. It actually has a loading area on the left, a transfer aliquoting station, and then a extraction purification, and then a thermocycler on the right-hand side. So it's a fully automated Roche instrument. Comes with the listing price of $500,000. And so we were using this instrument mainly for HIV, hepatitis B, hepatitis C, viral load testing up until this point. And very rapidly, SARS-CoV-2 take over most of the tests and occupies 90% of our testing capacity. So here you can see by March 28th, almost 2 weeks from that last picture, we had now 117 cases. Because of the population distribution in the United States, it's denser in the Northeast. That's why the circle is much bigger in the left-hand side, as you can see here. So we are situated here in Minnesota in the upper Midwest. And so the size of the circle represent the number of cases diagnosed in these areas. Now, as the pandemic progresses rapidly, we realized that we could not keep up with the number of test requests coming into our laboratory. Because we are a reference laboratory as well, and we receive specimens from all over the country. At 2,300 tests per day was only meeting about 25% of our test demand. So fortunately, we had some Abbott real-time PCR instrument known as the Abbott M2000, and we were able to launch this EUA assay, which was authorized by the FDA 6 days after the Roche assay. And this time we took about 5 days to launch this test. The testing capacity, however, was limited even with 3 M2000 system. And you can see that this is not a fully automated system. It has an extraction purification unit that's floor standing with an ABI 7500 real-time PCR system on the right. So it's semi-automated. But with 3 systems, we could only generate 1,500 tests per day. So combined with the Roche system, we could only produce 3,800 tests per day. Now, in the United States in March is the usual time for spring break. And with spring break, usually the college students go to beaches. And this was an interesting photo showing where the college student back in March, when they came to Fort Lauderdale, Florida for spring break, there's usually 50 to 60,000 college students congregating at Fort Lauderdale. And using their GPS signal, you can see that a week after spring break has ended, where all these students have ended up. And you can see that all these students went back to their campuses and colleges, spread the infection probably throughout the United States. It is at that time that the CDC in US and implemented masking and social distancing. But of course, it was too late to contain the pandemic. Now, as of July 1, so this is about 4 months after we started doing testing, the new confirmed cases per day in the United States has risen to 30 to 35,000 per day. And this is actually daily cases by July 1st. July 1st is the beginning of a long weekend in the United States for July 4th, our Independence Day in the United States. So usually there's family gathering, there's a lot of celebration to look at fireworks. So we kind of expected that there will be a surge of SARS-CoV-2 cases. And of course, we do see that. Our test volume is indicated on the right-hand side. The positive cases are indicated in orange. And we were doing total cumulative tests by this time, almost 750,000 tests in 4 months. Our positivity rate initially was around 14%. It had came down briefly, but then by July, end of June, it went back up to around 6 or 8%. Now, the cases continue to increase in the United States. So you can see that here by September 22nd, this is when actually colleges and schools started in the United States. But of course, most of the schools have gone to remote learning for colleges as well as high school, middle school, all the public schools. But you can see that these are the cases that are flourishing in the United States. And we actually, by this time, had to launch a third test. This is in June from Hologic, and in August from PerkinElmer, and then in September, Thermo Fisher. These are all FDA emergency authorized tests. So by September, which is about 6 months after we launched the first test with Roche, we are now offering 5 tests to meet the clinical demand. And our testing demand capacity by this time have reached 35,000 tests per day in our laboratory. So typically before the pandemic, we were only doing about 1,000 tests per day with 2 shifts in our laboratory staff. Now you can see that this is almost 35 times what we usually produce and generate in a day during the peak of the pandemic. This table just shows what kind of operations and tests we have to implement as well as obsolete because they were not very automated or the test performance were not up to expectations. So we had Cepheid rapid tests. So these are offered at the point of care in emergency room or outpatient clinic where we need to know within 1 hour whether the patient presenting with symptoms have COVID-19. I mentioned about the PerkinElmer Thermo Fisher. All this time, a lot of the assays are facing shortage of supplies and reagents. The transportation system in the United States have also faced tremendous pressure because of lack of workers. They were sick from COVID-19 and could not actually meet the supply chain pressure to supply all the diagnostic testing laboratory in the US with these kits. I also want to mention briefly that in April, this is by now about a year after we launched the PCR test from Roche, we implemented next generation sequencing for determining the pangolineage and clade of the virus because there are now resistance or non-response to some of the medication that are being used to treat COVID-19, mainly the monoclonal antibodies. By this time, we're facing Delta variant, a variant of concern. And then later on by October, November 2021, the rise of the Omicron variant also made some of the earlier FDA authorized monoclonal antibodies ineffective for treatment. I mentioned several of the tests that we performed in our laboratory. I mentioned 38,000, and you can see that not one method can meet the demand for the entire operation. And very often, our actual testing capacity is reduced because of shortage of personnel, shortage of supply, such as pipette tips are in great demand. And also the manufacturer just simply could not get us the kits, the reagents to the laboratory to meet the maximum capacity. So we were actually only producing about 30,000 tests at that time during the peak. We actually had grown from a laboratory of 35 personnel to 200 within 1 month to meet those 30,000 tests per day, and had to also make space for the biosafety level 2 cabinets. So a lot of the management is into personnel and space. We actually, my laboratory was actually testing viral hepatitis and HIV. We were not even doing any respiratory specimen for testing. So you can see that we actually had to make space for 15 biosafety cabinets. So this is the COBOS instrument where we actually have our personnel load open tubes of these specimens that are aliquoted within the biosafety hood. And very, very different than in China, where there's a lot more precaution in managing these specimens. You can see that we don't wear the total body protection space suit. What we do wear is protective eyewear, face shield, and masks. In order to accommodate the Abbott, Roche, and Thermo Fisher Hologic, we actually have to make space and have facility add these additional liquid handling system within a 1 week period. And my staff actually added this because our laboratory's name was just hepatitis HIV, but we had to add COVID-19 to reflect actually what we're doing. Almost 90% of our work during the past 2.5 years have been related to COVID-19. The challenges I mentioned briefly already is the shortage of the viral transport media, the swabs. Reagent kits are in short supply, but we also have incorrect transport of swab specimens sent to our lab, limited trained personnel, and of course, limited laboratory space. And of course, we also face with continual emergence of variants, which makes treatment very difficult and sustain the pandemic and the number of cases worldwide. I want to show you some of the things we receive in the laboratory. Here you can see that the viral transport media on the right-hand side, and if you don't provide sufficient viral transport media, we don't have enough volume to test. We also have universal transport media that contains guanidine thiocyanate. The guanidine thiocyanate is a stabilizer of nucleic acid. So it's good for molecular testing. But however, the downstream problem occurs when we have to disinfect the work area and the instrument with bleach. And the sodium hypochlorite bleach, when it comes in contact with guanidinium thiocyanate, it actually produces cyanide gas, which is poisonous to the staff. So we are very, very careful in rejecting any universal transport media that contains guanidine thiocyanate, because bleach is our major disinfectant in our laboratory, and that poses a hazard to our staff if it contains guanidine thiocyanate. We have also problematic swabs. You can see that this is a nasopharyngeal swab. They're very thin, but they're supposed to cut the knob and not jam the knob into these viral transport tube. And if one is not careful and unscrew the cap in an unprotected manner, the swab actually will function as a yo-yo and spring out of the tube and cause contamination to the work surface and also to the lab worker. We also have cracked swabs. Glass is not recommended because it can crack during transport. And you can see that this one actually had leaked out completely. And also push caps, because we are running out of viral transport media tubes. So many laboratories and providers are putting them into vacutainer tubes. And these tubes, when it's frozen or kept cooled, when it's brought to room temperature, will actually expand and actually cause the cap to pop up. So when the popping of these caps then cause potential hazard to our staff. So shortages of our staff continues. We had to emergently redeploy staff from other laboratories in our department, such as those in molecular genetics, hematology, pathology. The good thing is that because the patient care has been shifted mainly to outpatient, and very few patients are presenting to the hospital except those with severe COVID-19, the work in these other non-COVID testing laboratories have decreased. So we had extra personnel to help us meet the workload. So in November, so this is about 7 months after the first testing began, we had also contract employees up to 246 total. And then with the pandemic holding steady, by April, a year after the pandemic started, we have now about 200 permanent staff. For laboratory space, pre-pandemic, we had 1,000 square feet, and we had to quadruple the size to accommodate the number of instruments, staff, and testing that we have to accomplish. This is a picture of these instruments that we actually have to add. Remember, in the beginning of my presentation, I mentioned that we had about 2 Cobas 6800. And during the course of the year, we had to acquire 3 more instruments with a total of 5 Cobas 8800 systems. Our hallway are packed with reagents and supplies to accommodate the testing that we had to do at 30 to 35,000 tests per day. You can see that our space before the pandemic is in the blue. One corner, about 15,000 square feet. By May, we had to add additional space. And then by August, we had to add additional space to meet the demand. We still have periodic shortages of assays and reagents supplies, and we had to constantly adjust our workload to meet daily testing demand. In the last 6 months, you can see that during our weekend, our load tests workload is actually quite low. It's below 1,500 tests, but during weekday, it can go up 5 to 8 times higher, up to 8,000 tests per day. So it actually makes scheduling of our workforce very challenging. We also have to face the emergence of SARS-CoV-2 variants that affect our performance of the tests that are FDA authorized. So here I showed 3 assays. By this time, we almost had 200 FDA emergently authorized SARS-CoV-2 molecular tests. And 4 of these 240 or so, including our Thermo Fisher TaqPath combo assay, had mutations that they were affected by the mutations of the virus. And they actually either failed to amplify the spike protein sequence, or they failed to amplify the nuclear capsid, or there are specific mutations in the nuclear capsid that leads to false negative results. Fortunately, we have other assays in the lab that can overcome and detect these false negative specimens. Another challenge we face is the clinicians' desire to use CT values of the target, positive target, to help them guide clinical decision-making. And this is something we discourage here in the United States because the assays are not equal, and the intensity of the target that's amplified varies from one assay to another using the same specimen. So here, back in May 2020, the College of American Pathologists, which is our proficiency test regulation agency, sends out a proficiency test panel to different laboratories in the United States and asks them to report their CT values. And you can see that here, Abbott, the CT value is actually very, very low, 20 cycles, which means it's a very strong specimen. But for the CDC assay, the Gene Expert, and our Roche assay, the CT values are actually 10 cycles higher than the Abbott assay. And in fact, they vary anywhere from 5 to 10 cycles from one assay to another, testing the same specimens. And these are the median and the upper and lower range from 250 participating CAP accredited laboratories in the United States. So this is the reason why clinicians should be cautious in using CT values in determining whether this individual is infectious or in the path of recovery from COVID-19. I want to briefly mention about the sequencing assay that we implemented in April 2021. We use a commercially available assay from Thermo Fisher Scientific. It actually has 2 pools and amplifies 247 amplicons. And so this is a amplicon sequencing covering 99% of the SARS-CoV-2 genome. And the genome itself is around 30,000 base pair. We use manual extraction, which takes about 1 hour for 14 clinical samples with 2 controls, so total of 16 samples. And then it's loaded into the automated Genexus system and then to run overnight to generate results of the sequence. So this is a floor standing model. It's about 7 foot tall from Thermo Fisher Scientific. And we use a web-based tool to determine and analyze the sequence generated. So the FASTA files are analyzed by the Pangolin web tool and the Nextclade web tool and fed into our laboratory information system for reporting. During the past 18 months, we have been using sequencing for infection control and surveillance purposes. And because this does not directly affect patient care, we do not bill the patient or the insurance for this testing service. And the indication here was to see whether the patient who is persistently infected is actually having persistent infection or is actually reinfected with a new strain. We also can detect whether the patient is infected with which of the variant that is circulating at the time. For direct patient care purposes, the sequencing is used to see whether an individual who had fully been vaccinated has a vaccine escape variant, meaning that they have developed breakthrough infection and that they may or may not responded to the convalescent plasma therapy that was available for use at that time, or to the FDA emergently authorized monoclonal antibody therapy. So sequencing requires a minimum viral load. So with this assay, it requires about 50,000 copies per ml to generate good quality sequence. And in the course of this actually is 2022 from 2021. So about 1 year period, we have actually tested 678 specimens, but this represents only 68% of the requests that we received. So almost 1/3 were rejected because they did not have sufficient CT values or viral load. I want to show an example of how this test had helped patient management. So this was a 57-year-old woman who had interstitial lung disease, secondary lymphoma, received chemotherapy in February 2020. So this was just before the pandemic. Unfortunately, developed COVID in September 2020. For SARS-CoV-2 for a good 5 months, despite treating with different antiviral agents and monoclonal antibody. You can see that she was positive in October after a spontaneous resolution of her symptoms, but then persistently positive despite receiving intravenous remdesivir, convalescent plasma therapy, bamlanivimab, which is a monoclonal antibody. So you can see that during all this time with different immune therapy, she remained positive for a good 15 months, as late as December last year. And finally, when sotrovimab, monoclonal antibody, became available, she was still positive at that time. We were able to save all her strains and do sequencing, and each of these bar colors represent a mutations. And you can see that from the early strain in December 2020 and now in December 2021, there have been some mutations occurring in the strains that we isolated from her nasopharyngeal swab. When we did phylogenetic analysis, you can see that these strains are actually all related. She actually has been harboring the same strain of alpha variant of concern. Even though we have moved on to Delta and Omicron, she actually has been persistently infected with the alpha strain of SARS-CoV-2, although it has undergone certain mutations over the course of the year. I want to close by sharing with you that we currently in the United States, in our laboratory, as of last week, September 11th, has completed 6.8 million tests, with positivity rate at this time remaining around 77%. Our test turnaround time, and which speaks to the hard work of our laboratory staff and their teamwork, is that we were able to generate the results within 48 hours. So you can see that the blue and green lines represent the test turnaround time, and the y-axis represent hours. So in the United States, our benchmark is 48 hours of test turnaround time to generate the results. We currently do use antigen testing here at Mayo, and we are mainly using that in the emergency room, visiting family members, and also staff who may be feeling ill and wish to check and test themselves before they come to work. So these are the tests that we currently use. We use a commercially available antigen test from Lumira DX and gives a result in 12 minutes. Or they can self-test at home using this flow immunochromatography with results in 15 minutes. This is the current trend of COVID-19 in the United States. We are actually flattening out for the last 3 months. The total number of cases accumulated from the beginning of the pandemic has been around 95 million. So these are data from the CDC, and slightly over 1 million deaths. So as of yesterday, I believe the WHO General Director had said that the end of the pandemic is in sight because of significant drop, almost 25% drop of new cases worldwide. But in the United States, we have seen some drop, but we are actually flattening. We're not sure whether our trend in the United States matches that of worldwide. So I'd like to share with the audience that what we have learned over the past 2.5 years is that we have to be prepared for emergency response at all levels, whether it's the local within our work unit, our institution, our department, or even nationally. You can see that we had a lot of challenges with supplies and reagents, and it's very important to maintain close collaboration with the manufacturers and suppliers. During this 2.5 years, we, in the beginning, had weekly Zoom calls, meetings with our manufacturers. And it's only in the last 6 months that we have dropped the frequency of meetings down to once a month to maintain a stable supply chain issues. It's important also to maintain and recruit adequately trained laboratory personnel. And this is very important in the United States, where there's actually has been a decrease in interest in sustaining laboratory training programs to provide adequately trained graduates. Team effort is very important. So I think we all agree that the 同心协力 is very, very important to accomplish what we have accomplished and to meet the challenges of the crisis. And last but not least is institutional leadership support is very critical. I have been working at Mayo Clinic, and I must say that I've only seen my CEO once before the pandemic. And I was very touched during the 111 hours in March 2020, when we were working to get the first automated test up and running. Our CEO actually came to the laboratory for the first time to visit us on the weekend to give us moral support and ask how are we doing and how he can help. So with that, I'm going to end and pass the presentation to Yang 博士. Thank you.
Hello, Luis. Luis, I think you're mute.
Oh, sorry. Is that am I unmuted?
Oh, yeah. Right now, oh, your voice is back. Okay.
可以听到我了。
可以听到，可以听到。
抱歉哈。Dr. Xing Yang is currently the founder and the chairman of the Equinome Science. Did I say it properly? Acunum?
Yes, correct.
Yeah, he has more than 20 years of professional experiences in the healthcare industry. He has been involved in different medical diagnostic and life science companies. Dr. Yang has been established and also co-established different companies based on my understanding and made significant changes. Currently, he has been appointed as the Vice President R&D and the Head of Molecular Diagnostic Asian Pacific. Obviously, Dr. Yang has lots of achievements, lots of awards, lots of honors. So right now, we want to listen to him about his achievement. Yang, the microphone is yours. Yeah, whenever you are ready.
All right, I should be able to. Everyone see my slides?
Yes.
All right.
Yeah, thank you.
Okay. Thank you for the introduction, and I really enjoyed Dr. Yao's presentation. I'm gonna talk about COVID testing from a slightly different angle, more from, I think Dr. Yao is really running a testing lab, but I am a product developer. Most in my career, I involved in product development. So I'm gonna provide a little bit, kind of my feedback on my experience from the product development point of view. So COVID has really changed the diagnostic industry, particularly molecular diagnostics. In the past, I think, molecular diagnostic, PCR, nucleic assay tests, all these words, and probably only mean something to diagnostic people and people in Dr. Yao's lab. Now almost everyone knows this words, and in the past, I think the tests are all done in the labs. Now, Dr. Yao mentioned this lateral flow tests, and I arrived from China in San Diego last month. When I landed, when I was waiting for my luggage, I saw this picture, a bottom right corner picture in San Diego airport. And the airport offered 3 different tests: rapid antigen, rapid molecular, rapid RT-PCR. All these words, I think, really in the past is only stay within the diagnostic business people. I'm just, really surprised that this is showing in the airport, and I mean, I don't know how many people can really outside the diagnostic industry really understand the difference between rapid molecular NIAT versus rapid RT-PCR, right? So certainly the COVID has changed and certainly increased the awareness, understanding of this molecular tests. So I'm gonna share actually in both US and in China how COVID test has evolved since the beginning of the pandemic. And I think, at least to people like me in the diagnostic industry, I think a critical question is, well, first of all, it certainly changed the diagnostic industry, but how the diagnostic world change in the coming years? And I think that's the question. I don't think I will be able to provide some answers, but at least I will provide some of my thinking, and it is an interesting question to all of us in the diagnostic world. Let me start with the US. I mean, Dr. Yao mentioned in his lab, they had a cobus system, 2 cobus system before COVID started. Before COVID started, I think the molecular diagnostic in the US, different labs, different platforms. There are ones, for example, there's a high throughput instrument called cobus 6800 and 8800, and others, for example, I'm in San Diego, and Hologic in San Diego has this system called Panther. And depends on the throughput requirement. BD has a medium throughput instrument, and there also there's quite a few what I call the random access instruments, and these platforms, I think the most popular one is from Cepheid, one is from BioFire Filmer, and this all really sort of a sample to answer. You load the sample, you push button, you perform the test. And before COVID, there are quite a few different platforms in companies and launched the various different platforms. I list some of them at the bottom right corner. So, but in the laboratory, I think one of the most important difference, I guess, in the US is almost very little manual processing. It's really automation is quite in almost every lab. All this sort of molecular tests involves using automated platforms. The second point is almost all of these platforms are closed. By closed, I mean it's really that each instrument will only use the reagent from or assays from the company that built the platform. From regulatory point of view, most of these platforms are clear, moderate, complex. Some of them are clear waived. That's just a different clear standards for how automated it is or how easy it is to use for clear, moderate, complex that can be used by in the clinical labs that you don't need this specific PCR lab. Clear wave, that means you can almost use in the point of care setting. So the platforms are the automated platforms are almost everywhere, and in terms of testing in the lab, it's really decentralized the testing. Most of them are but still in the diagnostic labs. And before COVID, I was involved with this company called Biomus product in Asia, particularly this film array product. And before COVID, it's a big topic in the molecular diagnostic business that everybody's talking about, this syndromic test panel where you can depends on for each disease you can test almost all the pathogen that cause this infection. So syndromic panel was really started by Filmer, and there are quite a few other companies launching the similar platform. So that gives you everybody an idea in terms of before COVID started in the US, how we handle, how we process, how we test all this, doing all this molecular tests. I think in a way, Dr. Yao also shown in his lab, right? Really mainly was from what he was doing in terms of HIV, in terms of hepatitis, involved the platform like automated platform like Cobas 6800. And then when COVID hit, and if anyone is a fan of this author Michael Lewis, if you haven't read this book, I really encourage you read it. It's an interesting book. Talk about how U.S. government handle the COVID, and I found this interesting quote from this professor in UCSF, and so he was an innovative guy, and at the time, because it's as I mentioned, most of those diagnostic, all sample to answer platform are closed system, right? So it's really hard for you to develop your own assay on this instrument. So I think he had an interesting quote on this, like, all this automated platform have this really cool name, but you can't really do anything when yourself. And quickly, I think CDC stepping and as Dr. Yao also mentioned, right? So CDC even released all the assay design, and quickly FDA followed with the EUA. I mean, this emergency use authorization for a lot of PCR tests, and that's when the tests started. The test offering sort of pick up on various different platforms. And this is in May. You can see that May 2020, in terms of a laboratory, what laboratory is running the tests, and each laboratory, what kind of platform they use. And I think everybody remember Abbott's ID Now, which is made famous by Donald Trump, also made it into a lot of lab testing. So I think I think this kind of shows a similar picture as Dr. Yao was mentioned in his lab in terms of COVID testing. So the lab testing in terms of volume offering pickup, and Dr. Yao mentioned a lot of logistics, supply, all those issues. I thought from product point of view, one really interesting product is rapid antigen test. And notice how early it is. This was in May and July. May was, if I remember right, I think Quidel was the first one that had the UA for their rapid antigen, and shortly after that, I think BD followed up with their Verital. And those are rapid antigen tests, lateral flow tests. And for anybody in the business, we all know rapid antigen tests, when you compare the performance of that versus a PCR, clearly there's a sensitivity issue, right? And I don't know the specific COVID test number. I remember back in the days when I was dealing with flu A, B, RSV type of flu testing, I think lateral flow test sensitivity in the 70-80% range, where PCR is in the high 90s, right? So clearly there's an analytical sensitivity issue for rapid antigen tests. So why do we use it, right? And again, I thought there's some really smart people out there. Notice this is a paper on New England Journal of Medicine, published quite early in September 2020, and it talked about if in this COVID situation, when you want to do massive patient population screening, frequent use of this rapid test, you actually can meet certain demands. And so this paper talked about this they use the word of frequent use, right? As we all know now, FDA, there are multiple tests study done in the following month, and FDA later had a recommendation in terms of serial testing. You test every day or tested frequently. And Randex even have a report shows that serial rapid antigen test, it has the same performance as a PCR test. So I think this is for me from product point of view, I see there are people out there in this pandemic situation really explore different technology, different product to meet the clinical need. Of course, in the industry, COVID created a lot of business opportunity for companies. I'm just, I'm in San Diego, so here I'm just listing 3 COVID-related acquisition for San Diego-based company. I think there are quite a few more. And the other interesting thing, I think, for me is in the last couple of years, another important topic is home testing. We have seen quite a few this home test COVID, right? COVID home test. Yeah, I showed on the right-hand side, there's some of the common ones, Q Health, Visby, Lucera, and Detect. And so they all have a few things in common. For example, they are very simple, rapid, right? And most of them have a disposable instrument. And most of them have a very little, or some of them has almost no this sort of a sample prep is kind of a dilution or cleaning up type of approach. Most of them using isothermal amplification. I think Visby use PCR. And the cost of the COVID testing, this type of home testing varies, and some of them quite expensive. So all these companies, I think they launched their COVID testing during pandemic. Some of the company went public. Now in the field, in the business, we talk about home testing. Is that the future? What's going to happen after COVID? I think all these companies, they're thinking about the same thing. What are we going to do, right? And for me, it's talking to different people, understanding these platforms. For me, the question is, I'm sure there will be tests for home testing, but what is it, right? I'm speaking for myself. If I got a serious flu, I'm gonna and there is a accurate home testing I can buy in my local pharmacy. Why do it? Probably. But if I worry about myself getting cancer, why do a home test? Definitely not, right? Because for me, whether I don't need the time, I don't need to know right away, and whether it's false positive, false negative, to me, it's all bad, right? So and also the most important thing is cost and payment, right? And so I think that in the industry, home testing is right now in the diagnostic business is an interesting topic, particularly in the U.S. A lot of diagnostic company talked about it, and all those companies made money out of COVID. They're all thinking about home testing, and to me, there are a lot of issues, a lot of questions need to be answered, and beyond just technical questions. Let me switch gear to China. Let's follow the same kind of route. Let's start with COVID testing molecular testing before COVID in China. So molecular testing in China is quite different. Even today, it's still quite different from what's happening in the US. It's a very centralized testing model. You really use this four-room PCR lab. And this labs, the reason to set up this four-room is to prevent contamination, right? And so you have to put on this white jumpsuit, and then all this room has unidirection airflow. So all this complicated workflow. And so labs really, what they do is to accumulate in case like, Dr. Yao's lab running hepatitis tests in China. This is all mainly by hand. There's very little automation. So for labs to run for example, hepatitis test, they really have to accumulate samples today and then run the test tomorrow. And so report the results tomorrow night or the day after tomorrow. So it's really a 24 to 48 hours turnaround time. So in terms of application, what tests before COVID, what tests molecular tests run in China? It really just, three big category. Oncology has all this EGFR, KRAS, BRAF mutation. That business mainly dominated by only one player, so Moya Diagnostics in Xiamen, that they own probably 60-70% of the market share. And in most hospitals, I think they're really from infectious disease point of view, is only 1-2 tests. One is hepatitis, one is HPV. Hepatitis is probably now in the 50 million, overall China is 50 million tests every year. Growth rate less than 10%. There used to be a lot of players. Now it's pretty much down to the 3 I show in the top left corner. And HPV has over 30 million tests, is still growth rate very high. I think there's at least 20, probably 30, 40 companies have the approved product by Chinese FDA. So, and so in the lab, it's, really this 3 clinical application, which is something a lot of people don't understand. A lot of people think there's a whole lot of other tests. For example, before COVID, in China, very little respiratory infection in terms of all this flu, respiratory viruses and bacteria, almost no testing at all. Even today, still very little. So in China, it's very much of a centralized testing workflow, a lot of hands-on manual processing, almost no automation platform. And the main platform is really 96-well qPCR instrument. It's a 24 to 48 hours turnaround time. And in the lab, I think it's really instrument-wise is really ABI 7500 and Roche Cobas. That was before COVID started. And in Shanghai, in China, we have this company called Hongshi is making a pretty good PCR instrument at the time. I saw some of the top tier hospitals start using Hongshi instrument, but that's really before COVID. So when COVID hit, I think the Chinese FDA and the CDC did a similar thing. Chinese CDC released the COVID assay design, and then Chinese NMPA followed up with 8 companies EUA for their PCR kits. And China was really gonna push all the testing through this centralized model I was mentioning about. So they need labs, right? So over the last almost 3 years, China has built over 10,000 PCR labs all over China. And even that doesn't meet today's demand. So there are other labs. For example, this lab in a tent, I think, BGI calls this 火眼, right? This is 气膜实验室. And then there's a lot of there's a mobile bus, right? Putting a lab in a trailer essentially. And to the right you can see this trailer has 10 PCR instruments in there. It's 10 Hongshi PCR instrument in there. So when during COVID, when COVID started, China's strategy was very much continue to use the PCR centralized testing. Let's build more labs. I remember ABI 7500 instantly got sold all over. I mean, they ran out of stock. They took, I think China was calling every country, every ABI subsidiary in Asia, try to get all the instruments to China, quickly sold out. So that was China's early at the beginning of the strategy. And the other, I think the second strategy was try to automate stuff, right? So the first one is sample automation. How do we automate the nucleic acid extraction? I think there are 2 kind of categories approach. One is this so-called one-step assay where you don't do extraction. Even today, still some assays out there. You're essentially doing a dilution and dilute all the stuff that could inhibit PCR, and then run PCR right away. And then for example, I listed here Coyote, and then Dan. Those are companies over the years sold a lot of this type of approach. And the other bigger change, I think, is really this. I think Dr. Yao also mentioned similar platform in his presentation. Is this Kingfisher type of approach? Is really using a magnetic rod for nucleic acid extraction. This was probably China in addition in the last few years, in addition to 96 well plate PCR instrument, another piece of instrument has been sold broadly across China. Why this approach? I think this approach is simple. It's simply have a XYZ robot with a magnetic rod on top. You don't really need to develop any liquid handling. And I don't have a video here, but I think one of the in China, I think it's pretty much established this approach has a 1 to 2% of contamination, because you really have, there's a lot of vibrations, shaking when you're doing this extraction. The third approach is there are companies try to do the sample to answer or POCT platform. China today still, in the last few years, we have seen quite a few this type of platforms. Many of them claim they are the Chinese version of Cepheid Aging Expert or Chinese version of Biomuser Filmary. In reality, almost all of them really, when it comes to the automation, when it comes to performance, still have some gap. And I'm going to show here 2 video. This is I'm going to mute. On the left-hand side is Sensure, one of the biggest company in just molecular diagnostic in China. They launched a platform called iPontic, doing sort of a sample to answer. But as you can see, their workflow essentially it's putting an instrument in a box, but there's a person right next to it doing all the manual processing. On right-hand side is U star. You can see they are more automated, but still there's a few manual steps in terms of before they put it into the instrument for processing. So I think it's there are a lot of development of sample to answer automated platform in China, but in reality, not that many truly has this capability of a sample to answer. And then Omicron came to China. As we all know, Omicron has much higher transmission rate and higher positivity. But in China today, still COVID-19 is a category 2 infectious disease. What that means is, it's the same as HIV. It really means that to diagnose somebody as a true positive, it requires a CDC's confirmation, right? So a hospital really can do the test, but really when it comes to confirm somebody's positive, it has to be CDC labs. And China has adopted this dynamic zero COVID strategy. Well, to make this strategy work, it really needs massive sort of pure patient testing. I was unfortunately locked in Shanghai for almost 3 months during the Shanghai lockdown. And at the time we were talking about, a few of us also talking about how do we, if we want to, doing this whole Shanghai population screening in 24, 48 hours, it's not even possible. And so if we do a simple kind of a back of an envelope calculation, let's assume Shanghai has 25 million people. And in China, when they do this sort of a massive population-wide screening, it does pool testing. So you pull 10 people's sample into one tube and do the one sample testing. So that means you have 250,000 or 2.5 million tests, right? And assume each PCR instrument, we run 90 samples plus some controls. We can run 3 batches a day. If you do the math, to do the whole Shanghai, you need about 925 real-time PCR instruments, which is doable in a way, right? And China, in terms of product point of view, they continue to improve for example, there are quite a few companies develop this rapid COVID test, PCR part of it. So, 3D Mat that in Shanghai was the first one launch a 30 minutes PCR assay, right? And so there are other companies follow. So it's really model, in terms of testing is still focused on 96-well PCR instrument, centralized lab testing, and that's just how to quickly crank up the throughput of this approach. So if you're doing this, I think it's not that unthinkable to do a whole population in 24 hours. And so that was I think the Omicron, how they changed this testing in China. The other thing is, it was during this Omicron time that the government, in Chinese government, launched this rapid antigen test. Most of the tests, I don't know how many, I haven't seen any of my friends bought COVID testing themselves, but most of them are distributed by government. It's unclear why, they should use it. And so there is a lot of issues in clinical utility was not clearly explained. So when how they implement this massive patient population-wide screening testing today in China, most of I think they call it 常态化, right? So it's most of the city is 24, 72 hours. You need to do a COVID testing. So all this testing is not done by hospital. It's almost all done by third-party reference lab. This is all KingMed, this Dian, all this. And in certain provinces, for example, Zhejiang, Jiangsu, they build this, government built this 核酸检测基地. It's essentially a government lab specific for COVID testing. And the workflow is exactly like I described. It's a centralized testing. They don't use sample to answer platform because none of the sample to answer platform could match the throughput and cost requirement, right? As you can imagine, everybody has to be tested 24 or 48 or 72 hours. That cost is tremendous. So it's really on this building a lot of PCR labs, and you can see that a lot of this magnetic rod-based nucleic acid extraction instrument and PCR instrument. Since beginning of this year, lots of these instruments has been sold. It really based on this model, and I mentioned about this rapid PCR assay is also launched by a few companies. So this sort of a massive screening really now pushes sample collection. This becomes a bottleneck, and so I think if you pay attention to the Chinese media, you probably remember during Shanghai time, there's many provinces sending nurses to Shanghai to help with what? Mainly is really for sample collection. Go to each community, collect samples. And since then, I think government has this across major cities all have this sample collection booth. I think the requirements within walking 15 minutes, people should be able to get the sample collect. So that's how China does this COVID testing. And so I'm going to talk a little bit about what my product, our company, what we did, and is if it's all pool testing, what happens if one of the pool sample is positive? And so once it's positive, it really goes to the CDC, no longer the third reference lab. So CDC has to take over. And remember now, Omicron positivity rate is high. So actually it has, unlike, post-Wuhan time where positivity was quite low. Here, once the pool sample is positive, then, the CDC people quickly recollect the samples into single tube, and then you need to do confirmation. And for CDC people to confirm this person is positive, they need to use 2 assays, not just 1, 2 different PCR assays to run them, and both positive, then you can claim it's positive. So my company built this sample to answer instruments. I wouldn't go into the details. It's really a sample to answer instrument. You load the Dr. Yao talks about this sample collection tube, VTM tube. You open up, you take the cap off, you put the tube in and push button. It does all the testing, COVID testing in an hour. So we have sold quite a few instruments to different labs to do this confirmation. We have a lab near Shanghai runs this confirmation test every day. And recently in China, across China, including Tibet, we have sold instrument to do the for this specific purpose. So what's happening? Same question. What's happening to all these labs after COVID? When COVID is done, what are we going to do? All right, China has over 10,000 PCR labs, and each lab has lots of real-time PCR instruments. And COVID testing really pushed the molecular testing cost low, price is low. So I think same thing in the industry. Many companies, many people talk about what's next, and is it really pushing different tests through this same centralized model, or as many companies try to do POCT, really going to the clinic, go to发热门诊. What's the molecular testing look like? What does it look like after COVID? And so for that, we have a different opinion. We believe that the future of the diagnostic in China is really outside this full room centralized PCR model. I think this model really, even with all the instruments, still has just way too much manual labor. Simply, you can't find that many laboratory personnel to perform this test. So we hope to, as I shown you our instrument, we hope to use our instrument to bring all those tests out of centralized full room PCR lab into, other, for example, microbiology lab, all the core labs to do molecular testing, and through this we can offer Chinese physicians much better multiplex sensitive high performance molecular tests. And that's what COVID actually, one of the biggest changes is physicians or in China physicians, a lot of them now understand the power of molecular. So we hope to use our instrument to bring the test out of the centralized lab into a decentralized workflow. So maybe I can summarize is that COVID really made everybody know infectious disease and nuclear assay test. But in the U.S., what's the life after COVID? It is in the clinical labs. Before I think a lot of clinical labs don't do their own molecular tests. They just simply send out. Maybe through COVID, they acquire a lot of platform. Maybe they will do their own tests. Well, as I mentioned, what's the future of home testing? I clearly see there are future, but I don't think we understand this home testing that well. In China, 10,000 PCR labs. What are you going to do with it, right? And is it truly continue to use that lab to push different menu through, or really requires a different model to really increase the molecular diagnostic tests in the healthcare system. So I think with that, I give the microphone back to the organizer.
Thank you, Dr. Yang. Thank you, Dr. Yao. Let's give our two speakers a round of applause. Thank you so very much for your wonderful and instructive talks. Jerry, please take over the Q&A sections.
Okay, yeah. Thank you, Luis. Thank you, Dr. Yao. Thank you, Dr. Yang. Those are actually great presentation. Dr. Yao pretty much covered what is the US scenario, and Dr. Yang's presentation, besides talking about the technology involved in the COVID test, he also covered what happened in China. So very insightful. So there are some couple questions in the chat box. And the first one is, I think it's a question for Dr. Yao, mentioned how does 48 hours turnaround time compared with other lab? And what is the frequency of the mutation? And will those kits basically assay function with unknown mutation? And the third one will be, what will the mass spectrum will be a general universal surveillance method for compared to the PCR reagent here?
Sure. So I have to mention that the 48 hours is currently the standard set by Medicare, Medicaid in the United States for their beneficiary to actually get full reimbursement. So we use that as a benchmark. The test is actually $75, but if you can get the results within 48 hours, you actually get a bonus of $25. So you get $100 if you get the result out within 48 hours from collection. Now, obviously, if the patient is within our institution, we will get that result actually within the same day. So that's not a problem. But as a reference lab, it takes overnight shipping from a specimen from New Orleans or New York City to get to us, right? But when it gets to our lab, we will actually have the result within 24 hours. So it's actually quite a challenge for us for weekends, because we don't receive FedEx shipment on Saturday and Sunday. So the specimens that are taken on Saturday actually won't get to us until Tuesday morning, because FedEx will pick up Monday morning, and by the time we get it, will be Tuesday. So that's almost 4 days turnaround. And that is the same for all our reference lab here in the United States, like LabCorp, Quest, ARUP, and some of the smaller regional labs. But for within institution patient, generally 48 hours is not a problem. So regarding mass spectrometry, Now, keep in mind that mass spectrometry is a little bit messy because it's measuring proteins. And when you take a nasopharyngeal swab or a nasal swab, there's a lot of human debris and human cells. So when you have a mass spectrum, there's a lot of peaks. So you actually don't quite know which peak is actually belongs to the virus. And plus, sometimes the virus is present in small quantities. So it may be buried within other protein peaks. So they require some sort of a capture or enhancement. Agena Biosciences, AGENA, also based in San Diego, is a mass spectrometry producer. They actually have the assay called mass array. And what they have actually used is what they have actually they also have a FDA authorized assay, but it's PCR based. So instead of using a PCR thermal cycler to detect, it actually does PCR and then put it through the mass array to detect the amplicon, because you know exactly what the molecular weight and size of the amplicon. So they can actually do automation for 384 micro tidal well plate, but it still requires 7 hours for 384. So PCR is still relatively fast, and mass spectrometry people have tried, but just very messy because of the respiratory tract has other pathogens and human cells that makes it challenging.
Okay, thank you. Another question, I think it's for both speaker, because Dr. Yang talked about the home PCR test. So what's your opinion about home PCR test, Dr. Yao? Yeah.
I'll make it brief since Dr. Yang is the expert on this one. We currently use home testing, as I mentioned in one of my slides, for visitors coming to visit patients in the hospitals, family members, and also for staff. So when they come to the hospital, we do testing at the time of entry. And obviously, if they have no symptoms, we don't do any testing. We only do them if they have symptoms. So the problem with antigen tests is that it's not very sensitive compared to PCR. So the sensitivity is much better if the patient has symptoms. If it's not symptomatic, then the amount of virus present in the respiratory secretion is quite low, and you may get false negative. And we also use it for staff who have symptoms at home, and they're wondering whether this is influenza or something else, or is it SARS-CoV-2. So they can come to a drop-off area to pick up kits and do them at home, and then call in to see whether they're positive or negative. So
Okay.
it's a good test if you're symptomatic, not so good if you're not symptomatic and you're just, perhaps you had a recent contact and you're wondering whether you're infected. That's not a good test to use antigens.
Okay, so how about the PCR-based home test? Yeah. For example, Q, right? As I remember in one of your slide, Mayo also bought Q test product. Yeah, that's a isothermal based. Yeah.
Yeah. So Q test is still laboratory based and point of care based, but it's not home. There are a few that are home. I can't remember. There are at least 3 PCR. You can get them for $50. So that's available, but I don't think the Q one is home-based. I can't remember now. But I think that certainly will be better than the antigen tests, and that will be suitable for somebody who is perhaps a family contact who's not yet symptomatic. But once you're symptomatic, the antigen test is much cheaper and faster. You know, it's I recently bought one for travel to Europe to come back just before the US lifted the requirement for for PCR or antigen tests before returning. And it cost $20. So it's very good. Although I kind of chuckle because it's probably not sensitive enough, even if I'm one day before having symptoms.
I see. Yeah. Okay. So the third question from Dingbo and for both speaker, when do you think Chinese this quarantine policy will be ceased? And the yeah, maybe Dr. Yang first.
I have no opinion because I haven't
I
been there politically, and I think best for Dr. Yang to explain since he's been there 3 months trapped by this policy.
Yeah, well, I wouldn't be able to. I think this is not, this is not science, this is not technology. You can't really look into this from science or clinical, whatever angle you look. This is a purely political reason. So let's not discuss this topic.
Okay.
But I do have a follow-up question for Dr. Yang. One of the concern is the vaccine efficacy in China.
Right.
I think one of the reason the Chinese leadership felt for this kind of quarantine policy is that a lot of the population is still at risk, so we cannot afford to have an outbreak because the whole economy will crumble. Is the vaccine uptake rate poor?
Particularly among senior people.
And what's the reason?
Just simply vaccine resistance, I think. Simply just don't want to do this. I have to convince my own parents to do it. So so I think it's also a social issue. I think COVID is still to a lot of people a serious disease, right? So I think a lot of people don't. Anyway, so to answer from data point of view, there's still quite a bit vaccine hesitance among particularly senior people.
Okay, so the next question is from Nicole. Mentioned in terms of the product design, how to control the cost of the point of care for nucleic acid detection. Yeah, I think this is a big question.
Well, this is a really long this we could talk an hours, I guess. Well, you ask a very critical question. I think it comes down to, I think, from design point of view, for us, for example, I didn't have a chance to go into our product in detail. We completely abandoned this approach of try to do this sort of putting all the tests, all the steps of the test in a single disposable. We simply believe it's just too expensive. So we switched the design of using automated liquid handling, and our disposable is very simple. That's the approach we took. If you really want to do this, for example, I saw quite a few companies claim their Chinese version of Cepheid, Chinese version of FilmArray. Very few think about cost. Very few think about how it's very critical to control the parts of your disposable. So I think that's probably the two simple answer I can give you. But if you can contact me if you want to talk a little bit more. Honestly, this could talk hours.
Okay, thank you. Okay, let's answer, because we are kind of up to time. So let's answer another question here. From Zhenrong. What CT value do you recommend for positive sample by PCR? CT 30 is sufficient enough? Like, I guess this question is like a.
I think Dr. Yao answered that question. I think Dr. Yao answered the question in his talk, right?
Well, it really depends on the assay sensitivity. The CT value varies from one assay design to another. So a better measurement will be to use viral load. How many international units per ml of the viral transport media should you call positive? So Roche actually now has FDA EUA on their automated system for viral load testing, just released in July this year. And it can quantify down to 100 international units per ml. So when you look at some of these rapid tests that Dr. Yang mentioned, like the Cepheid and Lumira, they are around 1,000 to 2,000 IU per ml. And so the CT values obviously will be a little bit higher. But I think to control infection and transmission, probably 100 international units per ml should be the limit of sensitivity detection for the PCR or the molecular-based assay, ideally.
I will answer the question from a different angle. Dr. Yao talked about this international unit for viral load. I think Dr. Yao in his talk talked about it really depends on assay. Having a uniform threshold of CT is not the right way of doing it.
Right.
So I'm going to provide an answer, and I don't mean this in any negative way of saying the product is not good. So in my company, we deal with a Chinese company's assay. It's a good assay, by the way. But as you know, China has a cutoff value. So the assay we worked with, this company gave us to test. They purposely skipped the first 5 cycles. No fluorescent signal collect. And the purpose is to meet the Chinese requirement of that particular threshold, right? What I'm trying to say is by no means is saying that the product is not good. The product is good. What I'm trying to say is they try to artificially to meet a predetermined CT value. Or in the other way, what I'm trying to say is having a universal CT value doesn't make sense.
Mm-hmm.
Okay.
Totally agree.
Okay, thank you. Professor Zhou, do you want to have a close remark?
Yes.
Yeah, Joe, I think that Dr. Zhou can have a couple minutes to introduce the case and close the meeting. Yeah.
Well, we'll be together. Okay. Good evening and good morning, everyone. First, on behalf of the CAST USA, I want to thank Dr. Yao and Dr. Yang for the wonderful and very informative talks. I also want to thank Dr. Jinbo Liu and Dr. Zhe Mei for their efforts to organizing this wonderful webinar. This webinar is one of the series of events to celebrate the 30th anniversary of the CAST USA. The CAST USA is a non-political, non-profit organization founded in 1992. Our members are mainly composed of Chinese American professionals from various fields, such as science and technology, culture, education, law, finance, and the humanities. There are currently more than 10,000 members. At present, there are 15 regional chapters in the United States and several offices in China and the major cities in China, such as in Shanghai, Beijing, Guangzhou, Wuhan, etc. So this year marks the 30th anniversary of the CAST USA. So I'm very pleased to announce that we are organizing this year's annual meeting to celebrate the 30th anniversary of the CAST USA, and also to host the Global Innovation Summit, which will be held in October 28th to 29th in Boston, Massachusetts. We have assembled a group of internationally renowned scientists, including Dr. Wertzek, Nobel laureate at MIT, Dr. Qiu Chentong at Harvard, Dr. Song Chun-san at the Chinese University of Hong Kong to give our keynote speeches in our meeting. We will also award several Chinese American scientists who have made the outstanding contributions as the recipients of one of the CAST USA awards, namely the Outstanding Scientist Award, 卓越科学家奖, the Science and Technology Innovation Award, the 科技创新卓越奖, and the Outstanding Enterprise Leadership Award, 科技企业卓越领袖奖. All the recipients will also give the speeches in the meeting. We are also organizing several special sessions in the related emerging fields, such as in the new energy and environment, biomedical research, artificial intelligence, in vitro diagnostic technology, and the advances in physics and astronomy. And we are assembling well-known scientists and technologists in related fields as the panel members for the special sessions. So I would like to invite everyone to attend our annual meeting and the summit. Again, I want to thank Dr. Yao and Dr. Yang for this wonderful talk, and wish all of you to have a great rest of the weekend. Thank you.
Okay. Yeah, thank you. Yeah. Thank you, Dr. Yao. Thank you, Dr. Yang. Yeah. Really appreciate the wonderful talk. Yeah. Have a good weekend.
Thank you.
Thank
Bye-bye.
you. Bye, everyone.
Okay, thank you.
Thank you both. Thank you, Zhe. Thank you, Dr. Zhou. Thank you, everybody. Have a nice weekend. Yeah, sorry if we didn't answer all the questions. Yeah. Bye.
Yeah, we will post the video on the YouTube. Yeah, so if people don't see the entire session, they can still have chance to look at the video from YouTube. Yeah. Okay.
好，那谢谢大家，
谢谢大家啊，
谢谢你们啊
拜。
哎，再见。
谢谢金波，这样。
都主要是 Jerry，主要是哲，他一手组织。
啊，没，我就是帮着联系一下嘉宾。OK，
尤其这个 weekend，这个大家都很忙。
两位嘉宾也很辛苦。
对。
那我们所有的，
那我们再保持联系。
行，好的啊。
OK，
好，拜拜，再见，拜拜。
所有参会朋友，大家周末愉快，再见，拜。
拜。